What is DME? Why do you need to learn deep margin elevation technique in your practice? Are you tired of battling those impossible subgingival margins only to feel that you are fighting a losing battle? Hey there, my name is Dr. Devang Patel and I teach full mouth reconstruction and implant dentistry to dentists. I've written books about both the topics which are available on Amazon. My mentees call me the FMR guy. However, in the beginning of my career, I also struggled with those subgingival margins when I wanted to do adhesive dentistry. What if I tell you that there is a technique which I've been using for past 10 years to raise those subgingival margin predictably to do my adhesive dentistry, and that's called deep margin elevation. Now in the next few minutes, I'm going to share with you the secrets of deep margin elevation which I've been using for past 10 years to get the predictable results. Okay, so before we go into these 3 fundamental tips about deep margin elevation, we need to really answer 2 fundamental questions. One is, what is DME? Because some of you might not know deep margin elevation technique. And 2, why do you need to learn deep margin elevation technique in your practice? So let's start with understanding what is deep margin elevation. So deep margin elevation is simply a deep class 2 or MOD or deep restoration where the margin of your interproximal box is subgingival. So look at this case where patient came to me where patient had a huge amalgam. As usual, one of the cusp of the tooth was fractured, and when I removed all the amalgam, you can see how subgingival the margin is. The mesial margin you can't even see because it was so subgingival, the bleeding was everywhere. And now we want to save this tooth. The patient was referred to me initially for implant placement, but patient's only 22-year-old and we wanted to save this tooth. And because of that, we are trying to do everything to try and keep it, because I don't want to place implant for 22-year-old that early, because we all know that they don't last for lifetime. Nothing lasts for lifetime. So I said, okay, let's try and save the tooth. But as I said, in here you can see how deep the margin is, and we ended up doing this. Okay, this is using deep margin elevation technique, and did the composite, prepared the tooth for onlay, and now placed the onlay, and patient's really happy. And I'm sure this is going to last patient for considerable amount of years. Even if we borrow it for 5 more years or 8 years, it's still a success because we delayed that implant placement for certain amount of time. So this is really deep margin elevation where you want to restore the tooth, but the margin is subgingival. Now, when you had amalgam restoration, when you used to do amalgam, it wasn't a big problem because the isolation, it was a bit more forgiving than composite. But when you want to do adhesive dentistry, it's really, really important. So this is called deep margin elevation. Now let's answer the next question, why you need to learn about deep margin elevation and what kind of cases you would want to do when you do deep margin elevation. Okay, so you know what is deep margin elevation, but in what kind of cases you would want to use this technique for your patient? So number 1, as I said, is if you want to manage deep restoration, let's say class 2 cavity or MOD restoration, or you're doing direct composite, but you are struggling to put your matrix band into that sulcus and creating nice seal, this is the time you need to use deep margin elevation technique. It also facilitates bonding of your indirect restoration. So when you are moving the margin of the restoration above the gum, and now you're bonding your onlay on top of that margin, it is much easier to isolate. Now imagine you have subgingival margin, you want to now bond your crown or an onlay, and now you're struggling. So this is the time when we do deep margin elevation for onlays mainly. You don't usually do for crown. Generally, if it's a subgingival margin, if you're doing a crown, then I would use probably zirconia crown and cement it with GIC, glass ionomer cement, lutein glass ionomer cement. So because subgingival margin, just isolating by itself for cementation is really, really difficult. Now there are some people who would argue that you don't want to bond your onlay on a composite margin, but I use hybrid onlay Cera Smart, which has a composite resin component, and I use heated composite for bonding. Now, even if you're not doing that, you're using the lithium disilicate like Emax and you're bonding it with dual cure sort of resin cement, still the technique works in my hand. However, yes, it's a controversy around that whether you want to put your onlay on a margin or not. I've been doing this for 14 years and it works. So it makes your onlay preparation much easier. Now in this digital era, it makes scanning of your onlay as well much better, because if you're scanning enough, then you know that scanning subgingival margin is really difficult. So when you raise the margin, it makes it easier for you to scan. And also, as I showed you the example above before when we are discussing what is DME, it allows you to save teeth which may be not possible to save by doing just a crown. If you imagine that premolar which we just saw, if I start preparing that tooth for a crown, tooth would probably need post and core restoration, and even then the whole crown will be on post and core. You don't want to do that. So it really allows you to do restoration where there is not possible to do that. And that's why you do deep margin elevation. Okay, so now you know what is DME and why you would want to do DME. Let's dive into tip number 1, which is knowing when to do DME. Now, you know why to do DME and why it's really important for you to learn that skill. But let's say if you have a case like this where the premolar is quite badly broken down, you can't really save this tooth by just doing DME. You need to do either extract the tooth because it has a poor prognosis, there's not much enamel out there, or if you really want to do something, then you may have to do post and core restoration, because here, although it's similar to the case which I discussed before, there is still caries present. So once we remove the caries, there won't be much tooth tissue left. So this tooth needs to come out. Similarly, this tooth again, it's very difficult to save this tooth. And again, in my opinion, it's not for DME. And you might be wondering, like, why you're showing this kind of cases which is so obvious that you can't do DME. Now these are the cases were sent by some of the dentists to me asking whether it's possible to do DME or not, and that's the reason I'm showing it to you. Now cases like this where it's a huge amalgam restoration and you got some enamel there, this is a good case to do deep margin elevation, considering the fact that these amalgams are subgingival. When you remove it, you have some amount of tooth to place a composite and then do an indirect restoration. Or if you want direct, because I know many people prefer even direct composite crowns, I am not in that camp. So I do indirect onlays, but you can do whatever you wish by doing DME in these cases. And similar to here, this case where the margins were, this is equigingival, but once you remove the caries, it becomes a little bit deeper, then you can use some sort of a matrix system in order to do DME in this case. So make sure that you understand your limitations when you can do DME and how you can manage these cases. And sometimes it's better to do crown than struggle and do DME, because we want to do adhesive dentistry, but it's not always possible when you cannot isolate the tooth. So make sure that you understand which are the cases where you can do DME, and most of the time when I say you can place the matrix band, you can isolate the area, that's when you can do DME. And this is the point we discussed before, that when you're doing onlays, it helps when you do DME. If you're planning to do crown, then DME doesn't work. You need to make sure the margin of the crown needs to be on the tooth. The reason being that when you do onlay, as I said before, we are doing composite to composite bonding. Whereas if you're doing crown, and first of all, if it's a subgingival margin, impossible to isolate, and that's the reason you have the cement which is just not compatible to that, and you shouldn't be bonding subgingival margin when you cannot isolate. So you need to use conventional cement, and that's the reason for crowns this technique doesn't work. For onlays it works really well, or your simple direct restoration. So tip number 1 is make sure that you know when to do DME and when to say, call it a day and say, look, this is for a crown. And this comes with more and more experience. Some of the cases I can do DME, my mentees cannot do DME on those cases because they are just starting. So the more experience you're going to get, the more you'll be able to stretch yourself and get really good result. So make sure that you know your limitations. Okay, before I go ahead with the tip number 2, many times people ask me like, what kind of instruments do you use for deep margin elevation? Now, if you consider literally deep margin elevation is your normal class 2 MOD restoration, then you need to have the similar type of setup for that, plus a matrix system which is used for this particular technique. Apart from that, the rest of the situation is almost like the normal instrument. So for me, as you can see in the picture, I have my greater curve matrix band. I use OptiBond FL for all my bonding cases. I have some polishing burrs. I use injectable, genial injectable for the very tricky area in the box, or sometime where the box is really deep and you can isolate really nicely, but you can't really see whether you're adapting well or not. I tend to use sometime injectable. Now, genial injectable where to seal the margin. I don't use normal flowable composite because normal flowable composite have much more shrinkage rate, and that's the reason it's the weakest link, and that's why I don't use them on the base. But genial injectable is good, or you can use heated composite. That's what I've been using before even genial injectable came. So you can use heated composite in that in the box to make sure that it's really nicely adapted. Again, you don't want to push it too hard because you're struggling to put the band in, and most of the time you're not going to use wedge, which we'll discuss in a minute. You don't want to really push the composite too hard so that it comes out from the matrix band and then it just creates a nice big ledge. So make sure that use that genial injection, and that will make your life easy. I use some carving like Hollenbeck carver, which helps me carve my composite. I use number 12 blade, which is really important when you are doing DME, because if you have this excess amount of composite flesh, you can just remove it using number 12 blade. Of course, you need to be careful in the patient's mouth not to injure the patient, but this is the safest way in that sense to remove composite, because if you stick a burr interproximally, then it becomes really difficult to control, and you might damage your restoration and create some lesser dents, which can then harbor bacteria and food. So this is very simple instruments I use for my DME, nothing fancy, just our day-to-day instruments. Okay, so we are on tip number 2, and this is the most crucial tip. If you ignore everything else but keep this in mind, then you will be very good at doing deep margin elevation, which is seal is the king, which means when you're using your matrix band needs to be really good adapted towards the box. And there will be difficulty in using a wedge, because when you have subgingival margin and when you're using matrix band, you can't really push the wedge below your box, even more subgingival. So you're going to struggle in some cases to put a wedge so that you can really isolate the area. So you rely on your matrix band's capability in order to really make that seal. So for a long time I've used Toffel-Mayer matrix band. The sectional matrix bands are very tricky to use because by definition they are small sectional. You need something to hold the sectional matrix band, and many times the wedge will hold it, but again it's difficult to do that because if you are above coronal to the box when you put the wedge, you are going to create a big space, interdental space, when you do composite restoration. And I'll show you a case when I show you tip number 3 where the dentist did that. And what will happen is you'll have a very negative ledge, and I'll show you in a minute what I mean by that. But it's very difficult to put a wedge in there. So when you are doing sectional matrix band, it's very difficult, because the tooth is quite badly broken down, and that's where it's very tricky to use that matrix band, and that's why I don't use sectional matrix band for DME. And the problem with that is that the contour is not going to be as great as if you use a sectional matrix band. The interproximal contour can be really nice and rounded with sectional matrix band, whereas if you use DME, then many times what you happen is you can get a bit more straighter sort of a curvature. And that's why I do indirect onlays, and that's why I'm not relying on my DME technique to get me this good curvature. I'm relying on my indirect restoration to get really nice contact points. However, if you're doing a class 2 restoration, then you need to really understand this philosophy, and you need to make sure that you understand this before you do class 2 restoration. When you come to doing Toffel-Mayer matrix band, you can't use like this just simply and put it on patient's mouth, because this is not going to go past the maximum bulbosity and you will struggle. What you will see is when you tighten it, you start gap appearing at the base of the box, and you will see the blood seeping out and everything. And so that you need to make sure you modify this matrix band system. So the way you do is you use the scissors, and wherever the white area is on the photo, you cut that away. So only the black area or the gray band is visible. So it's very thin, and the point is, and you keep that 2-3 millimeter supragingival. So you make sure this is thick enough, so when you place the band, it's 2-3 millimeter supragingival. And when you use that, you are going to get much better result, and you will be able to push the band subgingivally. And this is really good, and it worked really well. However, as I can show you here, if you put without cutting the band, you will see a gap. You can see in this photo that, you know, I put the Toffel-Mayer matrix band and I've squeezed really tight, hard, and this is a typodont, arguably the easier you know, teeth, because you can push this subgingivally. Even then you can see a tiny gap. However, if you use something called greater curve matrix band or greater curvature band, then you will not have that problem. And here you can see I've used a greater curve matrix band, and that has perfectly sealed the area without even the need of the wedge. So make sure that you know what's this matrix system to use. And if you're using Toffel-Mayer, which I've used for 10 years without any issues, it's just a little bit more fiddly. Whereas if you use a greater curve sort of matrix band, then it really helps you negating that problem. It's called greater curve matrix band in the UK. DRE Composite sells it. I'm sure there will be some in US and Australia and India. There will be some suppliers. You have a Garrison. They also have a deep margin elevation band which are pre-cut, so you can use them as well. But I find these bands much easier to use. And you can see the difference here. On your left, you can see Toffel-Mayer matrix band. You can see that little bit of gap. On the right, you can see that the greater curve matrix band is sealed really, really well. And that's really the key when you're doing deep margin elevation. And whenever you're doing this, you need to really test it. You need to make sure there is no seepage of blood, there is no seepage of saliva, and you can really you know, have the really good seal. I would generally push air in it and make sure nothing's seeping out outside, because if there is any chance that there is leakage, then you need to abandon the procedure. Make sure you reseat the band properly, make sure you get that seal. Without that seal, the whole restoration, your indirect restoration, is going to fail. Problem with bonding is that, you know, it will not just pop out most of the time, because let's say if the tooth is like this, you have a good amount of tooth. But what you will have is patient will start getting secondary caries because of the leakage, and that's where the problem will start happening. And that's what we want to really avoid, that, you know, when it fails, it will fail in 4 or 5 years time, and now you've done the onlay and everything needs to be redone, and, you know, patient is much worse position to be in. So make sure you do a proper job from the beginning and make sure there is no leakage. And that's why I prefer this band system, and that's why I said selecting your matrix band system and making sure that you get this really nice seal is the key when it comes to restoring and doing deep margin elevation. So I hope you enjoyed the video so far. Now we are going to go to tip number 3, which is again a crucial, important tip when you are doing deep margin elevation, which is post-op radiograph. Make sure you take post-operative radiograph of every single case when you're doing DME. If I am doing, let's say, an adhesive onlay, I'm going to do my post-operative radiograph before I do preparation for my onlay, because I want to make sure my DME has done properly. And you can see here one of the case where one of the dentists has referred to me, where the dentist tried to do DME, and you can see what has happened, because dentist thought that he has really placed the matrix band properly, because it's very difficult sometimes if it's subgingival to see whether you are beyond the box. Okay, and this is where dentist thought that the matrix band adapted really well, tightened it, probably there was no bleeding, I'm not sure, and then placed some restoration, and you can see how much of a negative defect here is, right? So this is called negative overhang, where there is a huge surface of the tooth which is exposed, and this is after I have done DME. This is our finished DME. This is also done by using Toffel-Mayer matrix band, and that's where you can see here the contact points, right? So it's quite nice and, you know, not really curved. It's nice and straight, which is not ideal. But this tooth was going for an onlay because I've done a root canal treatment, and now you know, preparing for onlay. And that's the reason, you know, you could afford to have that, because you're going to prep it down and then make an onlay for that. But if you are doing a restoration, you need to be aware of it. With the greater curve matrix band, it's slightly less of an issue, but it can happen. You're never going to get, or you will rarely get, the curvature you want when you're doing a sectional matrix band. Now, there is a workaround of it. So what you can do, you really like to use sectional matrix band, then you can use the normal, you know, greater curve matrix band or equivalent to that kind of matrix band. Do a DME up to 2 mm above the gum, or even at the equigingival, and then remove the band and use a sectional matrix band to get a really nice curvature. So you can change and chop. Just make sure the isolation is the king. If you are swapping and if you have not used a rubber dam and the area gets contaminated, that composite, it's a faff to then reactivate the composite and redo the bond and everything like that. So make sure that, you know, it's nicely isolated before you remove the band and then change it with the sectional band. But this is really important. You need to make sure that you take post-operative radiograph after every single deep margin elevation case. Okay, so in summary, you need to make sure that you have a very good enamel around the tooth. So of course, you're not going to have enamel in the interproximal area, but make sure you have some enamel buccal, lingual, to have some sort of a composite bonding around that. If you're using any other bond apart from 4th generation bond, then consider changing it to 4th generation bond. So I use OptiBond FL, which is really basically primer separate, bond separate, and then you have an etch separately. So if you are doing dentine bonding, then I prefer 4th generation bond, which works really well. So make sure you have enamel, make sure you have a good bonding system, make sure that you have appropriate matrix system in order to do deep margin elevation. When you are using matrix system, make sure you have really nice seal around the tooth. And if you can't get the seal, then consider doing a little bit crown lengthening. If you're experienced enough, then you could use a high-speed burr in order to sort of create a little bit of you know, crown lengthening interproximally, just so that your matrix band seats. And if you are getting asked question that, you know, what about biological width? Now, when you have a really good seal with the bond, biological width is not an issue, especially when a bonding case is. When you are doing cementation like a crown, then you can get an issue with biological width. So make sure that you have a nice bonding, there is no bacterial leakage, and you won't have issue with the biological width. As you can see in the other radiograph, my onlay was almost at the level of bone, the DME. So you can do it with but you need to be very good at it. Once you've done DME, make sure that you take post-operative radiograph in order to make sure that, you know, you have done a proper job before proceeding to any indirect restoration. And you can see here, this patient was referred to me for implant again, but patient, because of the medical condition, could not have an implant. And this is the reason we did an onlay for this patient. And this is a case 7 years after I've done the onlay. And I'm not saying every single case you should attempt this, but once you learn the technique and once you understand how it works, you can push the boundaries. It looks really bad in this case, like in the sense that, you know, quite badly damaged. But if you look at carefully, I have enamel almost more than 180 degrees. Okay, only distally I cannot see enamel. Otherwise, you can see the enamel rim around the tooth, and that's the crucial bit. You have enamel where you can bond to, and that's where it will make or break when you're doing DME. So I hope you enjoyed the video. If you have, please click on subscribe and like, and I will see you in the next video.